Welcome all to the today's presentation. We begin with our session. We are continuing with the infection module, and today we will be starting with Neisseria gonorrhoeae. Okay, so what is the causative organism? It is the gram-negative Diplococcus. Okay, most of the time it will come in the examination that this will be the hint, gram-negative Diplococcus. Okay, so you think of Neisseria gonorrhoeae and it infects the columnar epithelium line mucosa. Okay, so primary sites of infection are the urethra, endocervix, rectum, pharynx, and conjunctiva. Okay, so the rectum, pharynx are not very common, but they are also sites of infection, especially in patients with MSM. Okay, those men having sex with men. Okay, transmission is direct inoculation of the infected secretion between the mucous membrane, and spread is by a transluminal or hematogenous spread. So clinical features will depend on the site of infection and other coexisting infection. So gonorrhea will present along with the chlamydia, trichomonas, then mycoplasma, candida albicans, and bacterial vaginosis. So these infections may be associated with it. Okay. So when there is a atypical symptoms, always think of the coexisting other infection. Okay. So if it is a penile urethral infection, in that particular case, 90% of patients will be symptomatic, and incubation period is short, around 2 to 5 days. Okay, symptoms will be dysuria and discharge. Discharge will be mucopurulent in nature, and if the complication happens, there will be epididymal or testicular pain and swelling. If it is a female urethral infection, in that particular case, the symptoms will be there, but it's mainly the dysuria. Okay, so urinary frequency generally not seen. If it is an endocervical infection, just wait for a minute. I will increase the font. It will be better. Yes. Yeah. So if it is a female urethral infection, in that particular case, main symptom will be dysuria, and urinary frequency generally not seen. If it is an endocervical infection, then the patient will present most commonly with the vaginal discharge, around 50% of cases, lower abdominal pain, intermenstrual bleeding, and menorrhagia are not very common. Examination findings in cases of gonorrhea, mucopurulent endocervical discharge, easily induced endocervical bleeding, and pelvic tenderness not very common unless there is a chlamydia co-infection. So if it is a chlamydia co-infection, we know that it is one of the common cause for PID. Think of pelvic tenderness more towards the chlamydia. Okay. Rectal infection, symptoms are usually asymptomatic. Anal discharge may be there, and up to 1/3 cases will have urogenital infection. Anal sex history may or may not be present. Then pharyngeal infection, mostly asymptomatic. Okay, so you can have a complicated gonorrhea, and this complicated gonorrhea, generally the spread is a local, that is a transluminal spread. In males, there may be epididymal orchitis, prostatitis, etc. And in females, there will be pelvic inflammatory disease. And here you should remember this numerical that PID is reported in 14% patients with gonorrhea. So what is the prevalence of PID in patients with gonorrhea? Around 14%. Okay. So next is a disseminated gonococcal infection, that is DGI. This is not very commonly asked, but here the spread is hematogenous spread, and features will be, there will be skin lesions, arthralgia, septic arthritis, and tenosynovitis. So coming to the diagnosis. Diagnosis is the detection of the Neisseria gonorrhoeae at the site of infection. So methods are NAAT and culture. But what is the preferred method? It is a NAAT. So in most of the infections, it is a NAAT. Okay, nucleic acid amplification test. No test has 100% sensitivity or specificity. So the choice of the test will be influenced by the clinical setting, transport and storage, local prevalence, and the lab availability. Okay, so on microscopy, what we are going to see? We will see gram-negative diplococci. They are intracellular in nature. Generally, they are seen in the polymorphonuclear cells. Okay, so you will get intracellular gram-negative diplococci. So when we are using the microscopy, what should be the site for the specimen collection? It may be penile urethra, 90-95% of cases, and for the microscopy, the penile urethra, if the patient is symptomatic, That is in 90-95% of cases. However, if it is a infection involving the vagina and the urethra, in that particular case, the site of swab is the vulvovaginal swab. Okay, so here the swab is taken from the vulvovagina. Okay, so if you are asked for the swab, select the vulvovagina. Okay, because penile urethra in symptomatic cases and it is seen in male. Okay, sorry. So important is when we do the NAAT testing, there is a cross reactivity with the commensal Neisseria, especially in pharynx. So if you have got this in atypical site, in that particular case, we have to do the confirmatory testing. Okay, if it is extragenital positive, then we have to do the confirmatory testing. Specimen of choice, if it is a penile urethra, first urine that is preferred, then urethral swab. And for female urethra, you take the vulvovaginal swab. Okay, that is what is the preferred. Okay, so vulvovaginal swab is the specimen of choice. This can be asked in the. Okay, so rectum and pharynx infection may be multi-site, multi-strain. Routine testing of all MSM is done for this pharyngeal infection and the rectal infection. Okay.
Sir, in post-hysterectomy, please specify.
Yeah. See, post-hysterectomy they have given, but this has not been asked. There is no clear evidence what exactly is to be tested, but urine plus vulvovaginal swab is taken for the NAAT. So again, NAAT is the test of choice, but vulvovaginal swab plus urine. Okay, and culture if the NAAT is positive. Okay, so they have mentioned urine plus vulvovaginal swab if it is a post-hysterectomy, but generally gonorrhea will be in the young reproductive age group. So most of the time, they patient will not be a post-hysterectomy in the scenario which is given. Okay. So generally, these infections are mostly seen in young and reproductive patients only. So what is the role of the culture? Essential for susceptibility testing. Resistance is increasing and evolving. So when to take the culture alongside of the NAAT in suspected cases and sexual contacts. All not positive cases, you have to send the culture before the treatment. So if there is a NAAT positive, you have to send the sample for the culture. Okay. So this is also one of the important point we have to remember. So from exam point, culture sensitivity will depend upon the time to plating. Best practice is the direct plating in clinic. Again, these are microbiological questions, not from our part 2 examination point of view. Reported sites of infection: urethra, sigmoid neovagina, penile skin. This is in patients who have got genital reconstructive surgery. Again, this is not frequently asked, so we will skip it. So this again not very frequently asked. We will concentrate only on the things which are exam oriented. Okay, so you have to test for the other infections. Okay, 19% will have chlamydia trachomatis associated. This also you should remember. How many percent of patients with gonorrhea will have associated chlamydia? It is a 19%. So PID is seen in 14% of cases, and chlamydia is associated in 19% of cases. Okay. Then timing of the testing. Testing should be done within 2 weeks of the post-exposure. If infection cannot be excluded, or if no epidemiological treatment, then repeat testing after the window period. So if the patient is presenting within 2 weeks, then you test the patient. Otherwise, you will give the epidemiological treatment. Okay. So NAAT is the primary diagnostics tool. Culture is mandatory for resistance. So if you get a NAAT positive, you will send the sample for the culture. Then vulvovaginal swab, best in women. First pass urine is best in men. Pharyngeal NAAT confirm if it is positive, then you will send the NAAT. Okay, and always you have to test these patients also for the chlamydia. Okay. Now coming to the management. The core principle is to explain the diagnosis clear to the patient, abstain from the sex until 7 days after both patient and partner will complete the treatment. Again, this particular option you should remember. So if you are having a treatment, so treatment along with the complete answer will be abstain from the sex until 7 days after both the patient and the partner will complete the treatment. Partner notification is mandatory and test of cure is required for all patients. Okay. So indications for the treatment: if there is an intracellular gram-positive diplococci on microscopy, or if there is a positive culture or positive NAAT, so any of these tests is positive, you will go ahead with the treatment. Okay. And sexual partner of the confirmed gonorrhea case is also to be treated. That is what is the indication for the treatment. What is the first line of treatment? The first line of treatment is a ceftriaxone, that is 1 gram single dose. Ceftriaxone 1 gram single dose, okay, intramuscularly. It will cover the urogenital, rectal, and the pharyngeal. So it will cover multi-site infection. Ceftriaxone 1 gram single dose. So, and along with that, we have to advise the abstinence for 7 days after completion of the treatment for both the partners. Uh, if the susceptibility is confirmed, in that particular case, ciprofloxacin can be used if it is a susceptible. Okay, the dose is 500 milligram single dose only if proven susceptible at all sites. Okay, this is a optional. Avoid ciprofloxacin. Prior quinolone adverse effects are there, or if age is more than 60, or if there is a steroid use, or the renal disease, or the transplantation. Okay. Why no dual therapy is previously there used to be the dual therapy, but now only the ceftriaxone is preferred. Okay, so no proven synergy with ceftriaxone for azithromycin resistance is increased. So 1 gram azithro is inadequate for the treatment failure. It will be a treatment failure. Okay, 2 gram azithro will lead to the GI side effects and resistance selection. Okay, so hence this choice of treatment is the ceftriaxone monotherapy only, otherwise not. So higher failure rates, especially for pharyngeal infections, prefer dual therapy with azithromycin 2 gram. Okay, so these are the alternative regimens. Okay, if IM is contraindicated or refused, then oral treatment can be used. Cefixime 400 milligram per oral plus azithromycin 2 gram per oral. Severe beta-lactam allergies, then go for gentamicin 250 milligram intramuscularly and azithromycin. So here azithromycin is always 2 gram when the dual therapy is given, especially if ceftriaxone is not possible. Okay, and especially for pharyngeal infection, then only you use dual therapy in with azithromycin 2 gram. Okay, otherwise not routinely preferred. Okay.
Okay.
So management of complicated gonorrhea. We have seen the complicated gonorrhea will be either pelvic inflammatory disease or epidemiologitis or either conjunctivitis or arthritis. So these are the cases of complicated gonorrhea. So what is the treatment for PID? It is a ceftriaxone 1 gram intramuscular dose plus standard PID regime. That is a 14 days you have to treat this pain. If it is epidermolysis, that is ceftriaxone 1 gram IM along with the standard epidermolysis regime. Then gonococcal conjunctivitis, ceftriaxone 1 gram single dose along with irrigation with the normal saline. Okay. Disseminated gonococcal infection, ceftriaxone is the drug of choice. That is 1 gram intramuscularly IV daily. Then cefotaxime 1 gram IV 8 hourly, and this is to be treated for 7 days. Okay, and we will switch to the oral after the improvement, maybe after 24 to 48 hours will shift in cases of disseminated gonococcal infection. This you should remember, because most of the time these infections they are asking even in pregnant women. Last time we have discussed with vulvovaginal candidiasis and all. Okay, so the ceftriaxone is safe, so go for ceftriaxone. Then other option is a spectinomycin 2 gram intramuscularly. Okay, and azithromycin 2 gram per hour only if it is susceptible and there is no other alternative, then only azithromycin. So we have in pregnancy ceftriaxone, spectinomycin, and azithromycin. Ceftriaxone is the first choice, then spectinomycin, and then azithromycin 2 gram only if the susceptible and there is no other alternative. Okay.
Is
For
spectinomycin safe in breastfeeding?
yeah,
Is
they have given no
spectinomycin, is it?
pregnancy. See, they have given a pregnancy and breastfeeding.
It,
This is
okay, okay. So
ceftriaxone,
it is safe.
spectinomycin. Yeah, yeah. And what is to be avoided? That also they have mentioned. Avoid quinolones and the tetracyclines. Okay. Chlamydia associated If already received azithromycin 2 gram, then no further treatment is required. Otherwise, chlamydia treatment will be required as per the guideline. Okay. Then sexual partners, yes. Here, who to notify? Symptomatic male urethritis, partners in the last 2 weeks. Okay. Asymptomatic or extragenital infection, partners in the last 3 months. Okay. So symptomatic, generally symptomatic patients, remember, you have to take trace the partner or notify the partner in the last 2 weeks. And treatment of contacts. If the contact is presenting after 14 days, treat only if the test is positive. If you there is a contact within last 14 days or up to 14 days, then consider epidemiological treatment after the risk assessment. Okay. So if the partner is coming within 14 days or up to 14 days, you will give epidemiological treatment, and after 14 days only if the test is positive. Okay. What is the test of cure? Test of cure is mandatory. Who needs extra emphasis? Persistent symptoms, pharyngeal infection, non-first line regimen, and infection acquired in Asia Pacific region. Okay. So method of
So
testing
this
for
partner testing is different for males as well as females. For males, it is testing only up to 2 weeks, and for the females, it is 3 months or
no, no,
six
no, no.
months.
Yeah, it is 14 partners in the last 3 months. If there is a symptomatic male urethritis, you have to notify the partners in the last 2 weeks. Okay. But if the patient is asymptomatic or if it is an extragenital infection, then all partners in the last 3 months. That is what they have mentioned. Okay. If it
Okay,
is a
okay,
male urethritis, then partners in the last 2 weeks. If it is a asymptomatic or extragenital infection, then you will have to go back 3 months. Okay.
okay, ठीक,
And
okay,
after that, what will be the treatment? Treatment will depend upon the duration of the presentation of the exposure. Okay. So if it is immediately or in the recent infection, then you will give epidemiological treatment. If it is a late or more than 14 days, then you will treat only if test is positive. Otherwise, you will not treat. Okay. Then test of cure. Test of cure is mandatory if the symptoms are persistent, pharyngeal infection is there, non-first line region. Okay. Method and timing: symptomatic culture after 72 hours post treatment, and if it is asymptomatic, then go for NAAT. And if you do the NAAT, you have to do the culture. Okay. So that is what you have to do. Okay. So symptomatic cases, you have to do the culture. Asymptomatic, you will be doing the NAAT. Okay.
okay.
Treatment failure. So persistent symptoms, positive test of cure. So treatment failure, we will think of the treatment if the symptoms are persistent or if there is a positive test of cure, that means the treatment has failed. Okay, then we have to think about the resistance, reinfection, and non-viable DNA or early NAT.